Today, our guest speaker is Dr. Ranjit Kumar Sahu from AIMS, Delhi. He's MD Internal Medicine and DM Medical Oncology. He's additional professor, Department of Medical Oncology at IRCH AIMS, New Delhi. He's going to speak to us on acute myeloblastic leukemia in India, hurdles and opportunities in the current era. I won't have an opportunity to tell you more about him. So I must say at this stage only, he's a brilliant clinician, brilliant academician, and that sums up everything. This webinar is brought to you by Mumbai Hematology Group. Today's episode is supported by Zydus. And as usual, all these episodes are managed by Perfect Square. I'm thankful to Mr. Ashish Kumar, Sumit Madan and their team from Zydus for supporting our academic activities. Mr. Yash Kalpesh and the team from Perfect Square for flawless execution. The Executive Committee of Mumbai Hematology Group for being so liberal to give me all these permissions to conduct anything that I desire. Our chief guest of the day, and we are absolutely honored by his participation, Dr. Shyam Agarwal from Delhi. Our guest speaker, of course, Dr. Ranjit Kumar Sahu. All our discussants, and they are in large number today, and they're all eminent hematologists, medical oncologists, or budding stars in these fields. You participants, for sparing your Sunday morning, or maybe afternoon or evening, we have registration from 27 countries today. Our discussants are a large number of very important personalities from India, and they are alphabetically put up over here. And I'll take 5 minutes to introduce them very briefly to you. We have Dr. A.R. Jaswanthini from Yashoda, Hyderabad. Dr. Abhishek Ranjan from Center for Blood Disease, Lalpur, Ranchi. Dr. Aditi Jain from Safdarjung Hospital, Delhi. Dr. Akanksha Chaudhary from Kidwai, Bangalore. Dr. Akash Khandelwal from BLK Max Hospital, Delhi. Dr. Akshaya Mandloi from TMH, Varanasi. Dr. Amrita Chakrabarti from Max Hospital, Delhi. Dr. Avriti Baveja from Himalayan Institute of Medical Sciences, Dehradun. Dr. Chandrasekhar Bendi from Mahatma Gandhi Cancer Hospital, Vizag. Dr. Ketan Modak from National Cancer Institute, Nagpur. Dr. Krishna Ratnam Kannan from Sri Ramachandra Medical Center, Chennai. Dr. Kunal Goyal from Tata, Varanasi. Lieutenant Colonel Dr. Kundan Mishra from R&R, New Delhi. Dr. Mohammed Rifai from Government Medical College, Calicut. Dr. Mukul Agarwal from AIMS, Delhi. Dr. Naveed Tamboli from Dinanath Mangeshkar Hospital, Pune. Dr. Nitin Gupta from Sir Gangaram Hospital, New Delhi. Colonel Dr. P. Suresh from R&R, Delhi. Dr. Ramesh Balasubramaniam from Meenakshi Mission Hospital, Madurai. Dr. Ayaz Ahmed from Rajiv Gandhi Cancer Institute, New Delhi. Dr. Rizwan Akhtar from SGPGI, Lucknow. Dr. Mohammad Rizwan Sheikh from Max Super Specialty Hospital, Saket, Delhi. Dr. Saswata Saha from TMC, Mumbai. Dr. Savitri Singh from PGI, Noida. Dr. Swati Banka from from Nagpur. Dr. Tulika Sheth from AIMS, New Delhi. And now it's time to introduce our chief guest for the day. I'm once again extremely honored by his kind presence. He's my friend and colleague, Dr. Shyam Agarwal, who requires no introduction to anybody in the field of medical oncology or hematology from this country, or for that matter from in this world. Very briefly, he is senior consultant medical oncologist and hematologist at the prestigious Sir Gangaram Hospital, Delhi. He completed his MBBS from Chandigarh and then MD Medicine from Medical College, Rohtak. After this, he underwent a special training at AIIMS, New Delhi. He has over 3 decades, maybe 4 decades of clinical experience. He is also a bone marrow transplant expert from University of California, Los Angeles, UCLA, USA, and St. Vincent Hospital, Sydney. Being a renowned oncologist, he has been honored with many awards and recognitions throughout his long, illustrious career. He's been actively involved in creating awareness programs for bone marrow transplant and colonic cancer. He has been a source of inspiration and a guiding light for many people in the society at large. I can go on and on, but I think it's time to request him to inaugurate our today's webinar and give us some words of wisdom. Thanks, and over to you, Shyam.
So thank you very much, Professor M.B. Agarwal and the sponsors for inviting me to be the chief guest for today's program being organized by the Maharashtra Hematology Group this morning. And I'm extremely pleased to see a mix of senior and middle and junior level hematologists from across the country, and absolute delight to hear that the program is so successful that people have joined from over 25 countries. So I've been requested to not say anything on AML, just to talk about hematologic disorders and hematologic malignancies, to inspire people to work in the field of hematology and hematology oncology. So when you're supposed to inspire, I think inspiration should come from the work which people have done over the years, which has sort of brought us to this level of understanding of the subject. And hematological malignancies, which has been our forte as well, has really progressed over the last 5 to 6 decades. And to start with, it was basically William Harvey who told us about the circulatory system. Subsequently, Landsteiner, who gave us the understanding of blood cells. And then down the line, we have the staining for understanding of different type of blood cells. So people have really worked over the years. But I think the major breakthroughs in hematologic malignancies started coming when Janet Rowley, started to understand the chromosomal disturbances related to CML. And then, of course, it has been followed up by now what we have is the molecular biology of hematological malignancies, which has really come in a very big way for our understanding of a variety of malignancies, including hematologic malignancies. So this is an era where we understand that all cancers, including the hematologic malignancies, are a result of genetic aberrations. So earlier, the tests which were required to be done were extremely difficult, time-consuming, and expensive. But now that we have NGS, we have CGP, which even gives us a better handle on the chromosomal, not only chromosomal, but also the molecular aberrations, which can help us to figure out what treatment we should be doing. And CML was the first disease in cancers where targeted therapy in the form of imatinib really opened the gateway. And we have really looked forward in that direction. But I think over the last few years, in addition to the targeted drugs, which are based on the molecular aberrations of a variety of hematologic malignancies, I mean, we have 2 or 3 important developments in which we are, heading, which we need to understand and actually since India is really contributing now to the development, so we should get engaged. One is the area of monoclonal antibodies, which was started, by the Nobel laureates Kohler and Milstein with the hybridoma technology. But, we have a lot of monoclonal antibodies, as we understand, for example, rituximab, and now, of course, for solid cancers and other malignancies. But I think there's a new era which we are seeing now, which is the development of antibody drug conjugates. And I think we as clinicians and also the pharma entrepreneurs should join this, because this is a new way of treating malignant disorders. And we have, drugs like brentuximab, vedotin, and now polatuzumab, which are, approved now for patients with different malignancies, and these are group of antibody drug conjugates. The second thing which we see in the management of hematological malignancies is the era of CAR T cell development. And I think India has lagged behind so far in that area. So I'll urge, because you have these young people, and there is reasonable automation now available for developing CAR T cells. And I think it is our duty now to sort of get into, with the administration of your institution, to get programs going, because now you can treat ALLs, you can treat lymphomas, you can treat myelomas, and this field is going to grow. Finally, I'd like to say a word about CRISPR, because CRISPR, Jennifer Doudna has now, with the help of editing T cells through CRISPR, is talking about off-the-shelf CAR T cells. So I think there's a lot of basic research which is required, and now the country has resources, and you really need to be on it, sort of write projects and get grants from your institution or from DBT, DST, so as to stay, in front and keep the country in front for development of latest technologies to understand cancers and to treat cancers. So, in my institution, we've been working on the understanding of NHL. And let me say this, somehow I haven't gotten a good feedback from the laboratories, for example, to understand the NGS for NHLs, which we've been trying for the last 1 year. So I think we need to join hands with the industry to understand the cancer biology, and including the hematologic cancers. And I think the area which needs attention at the moment would be the development of relatively cheaper, CAR T cells, which could take the country forward in a very, very positive way. So I look forward to attending this webinar, which is focused on acute myelogenous leukemia. And again, in this area, we've seen, going a little not away from chemotherapy, but you do have additional agents now to target the appropriate cancers depending upon the NGS. So with this, I congratulate Dr. Andy Agarwal and the entire team he has put forward for the discussion on AML. We look forward to a very, very interactive session. Thank you very much.
Thank you, Dr. Shyam. In the time that I could give you, you have so beautifully summarized all the advances that are occurring and changing the field of hematology, especially hemato-oncology. Just last evening, we had a wonderful talk from Seattle on inotuzumab, blinatumomab, and CAR T in adult B-cell acute lymphoblastic leukemia, followed by almost an hour-long discussion with our colleagues. And you just added to that today.
Absolutely.
Now we come to our speaker of the day, Dr. Ranjit Sahu. He has been introduced just a couple of moments ago. I may just again say that he is a brilliant researcher, brilliant academician, brilliant clinician. He's very young, so he has got miles and miles to go. And I think he's going to shine the name of this country and his institution all around the world. I'm very impressed by his talks, his participation, his academic interest, his publications, right up to international journals, and his passion for acute myeloblastic leukemia. He has always obliged us by joining us as speaker discussant, coming down all the way from Delhi to Mumbai, participating in our conferences, and not only giving his talk, but even hanging on in the auditorium to actively participate in the discussion when others present. So I will not take much time. Ranjit, over to you.
Are my slides moving?
Yeah, perfect.
Thank you very much, sir, for that kind introduction. Whatever you have introduced me, if I could actually achieve 20-30% of it, I would be very lucky in this line. Okay, so today's talk is about AML. I mean, I would rather be focusing on what is happening in our context. And I do not have any conflicts to share. And my apologies for any background noises, be it human or non-human. And if at all there are internet issues. So AML is the most common aggressive adult leukemia. In both US and Europe, there are close to 20,000 new cases each year. Close to 70% of patients are over the age of 16. The information on clinical outcome in AML comes from either large national cooperative group studies or industry-sponsored clinical trials. Now, let's concentrate on what is happening in our country. I have actually taken these 3 studies. 2 are from our own institute. The other one is from CMC Velo. And I have compared it with a retrospective analysis of MD Anderson cancer over a 2 decades period. As you could see, the age of our patients, they are at least 2 or 3 decades younger. The WBC count at presentation could be higher in our cases. The cytogenetics are mostly good or intermediate. The poor risk are close to 10 or 20%. As compared to what is happening in MD Anderson cancer, it is close to 30%. Now, I would want to focus on this part. The performance starters at the presentation in our country, it could be 30% will present at close to 3 to 4. And this is from CMC Velo. If you club all this PS2 and PS3-4, it is close to 25% patients. The other part which is of interest is between 90 to 2000, the patients that have received treatment at our institute is close to 51%. It could be just because of the cost. And between 2000 to 2011, this number has actually increased to beyond 80%. When you look at the same number for CMC Velo, it is only 30% of our patients are receiving treatment. It could just be due to the financial constraints. Now, the other part which is important in and across India is the induction mortality. Between 2000 and 2011, this is a retrospective analysis of ours, the induction mortality was a little less than 20%. And in the CMC Velo, in this 29% patients that have received treatment, the induction mortality is 25%. Now, mind you, this is between 2012 to 2014. And the most common cause of induction mortality, early mortality in the first 30 days is because of infection or bleeding. Now, this is one thing which has been identified over last 1 decade. If you look into our data, between 2000 and 2006, we analyzed close to 100 cases and 25% patient had bacteremia, and most of it was actually because of ESBLs. When you look into this prospective study from CMC Velo, you could see that the incidence of MDR GNB is actually close to 39%, and the attributable mortality to this gram-negative sepsis is close to 50%. And this is for Cancer Institute idea, same data. So close to 40 to 45% of our patients, the mortality is attributable to MDR gram-negative sepsis. Now let's come to the West. These are the survival curves for CR and from MRC clinical trials. And if you see patients who have less than 50 years, the survival is in excess of 45 to 50%. And this is for MRC, the same numbers, and they are pretty much repetitive across West. When we look into our long-term outcomes in AML in India, this is the data from our institute. It is close to 500 patients. As you could see, there is actually no difference between good and intermediate risk, and the poor risk is also not. No, I mean the curves are almost merging into each other. So good and intermediate, they are doing better than poor risk, but not enough. So close to 35% of our patients are getting cured with whatever way we are treating them. Now, the other information is from Tata Memorial Hospital. This is across all the acute leukemias. If you look at acute promyelocytic leukemia, it is pretty much cured in close to 85% of the cases, and the number is 100. When you look into AML, the same thing is happening even here. That close to 30 or 35% of cases are getting cured. And when you look into the curves, the first dip is coming in the first month itself. Now let's concentrate on some recent data. And now this data is coming from a randomized clinical trial, which is a multi-center clinical trial in pediatric AML patient defined by less than 18 years age. This is pretty recent, from 2014 to 2019, close to 150 patients. Here as well, when you look into the curve, there is an initial dip. And in this study, the induction mortality was close to 17%. So you could imagine the induction mortality in adult is only going to increase. Even in this pediatric patient, the overall long-term outcome is not great. It is close to 40%. Now, this is another interesting information. How many patients are not getting treatment? In our institute, it is close to 15% patients. It could be due to financial constraints or patients at very, very advanced stage of presentation. In Tata Memorial Hospital, for all acute leukemias, this number is close to 35%. In CMC, it could be 70%. So these are costly diseases, as you could see. This is the data I have taken from Tata Memorial Hospital, where the number of patients are close to 35%. They are excluded because of upfront palliation or loss to follow-up while on investigation. The most common cause that was cited in that paper was it is mainly due to the financial constraints. Now, this analysis is coming from CMC Velo, and this was a prospective study. So patients who are not proceeding for treatment, 80% it is due to the lack of financial resources. And then there are lack of social support, which is also very much common to the financial resources. So close to 90 to 95% of our patients, they are either not getting treatment because of the finances or from the social support. Because most of these patients, they are getting induced at tertiary centers or centers which has got expertise in private, and it could be very costly. Now, these are the cost estimates from CMC Velo during that period from 2014 to 19. If you could see, if a pediatric AML, the cost of induction is close to 500,000, and if it is adult, it is close to 750,000. And the whole treatment will cost somewhere around 14 to 20 lakhs. The problem is the way these patients present. I mean, our median age is in the 30s. In the 30s, like many of us, we are only starting to earn. And some of us, a good number of our patients will be the breadwinners for the family. To get this much sums, I mean, to get the treatment done, it could be very, very difficult. So this is a major issue, that we do not have a lot of support. So the hurdles of AML patients in India is, it is an aggressive leukemia in younger patients, who are between 30 to 40s in different studies. There is higher percentage of patients who are not taking treatment. Let's put that number at somewhere around 20 to 30%. Early infection related mortality. A decade back, it used to be 25%. In some recent analysis, when it is through across the centers, the variability is something from 6% to 40%. So the induction mortality in some institutions, it could be a little more higher. And even if these patients, I mean, let's say 30% of these patients are dying in the first month, the relapses and the rest 70%, they had to do well. The relapses are closer to 50% in such cases. So the long-term outcome in our AML patients is close to 35%. We should ideally be been 40 or 45% could have been a better number. So what are the possible solution? I mean, patients who are having aggressive leukemia, the treatment should be very early. When the patients are getting referred from the peripheral hospitals at very wide white cell count, these patients are also not getting hydroxyurea, which could be an easy drug. They are very safe and they are pretty much available across the country. But it is because of the unawareness from the physician's point of view that these patients are landing up at very high counts. Now, high percentage of patients are not taking treatment. So we should be able to provide them some low cost treatment. This low cost treatment, I assume that this would any day be better than the best supportive care. And there could be a chance with low cost treatment in such cases, but there are no chances when these patients go on best supportive care or palliative care. The early infection related mortality. Now, many of these patients, they have received antibiotics before the presentation to the tertiary care hospitals. There could be a lot of gut dysbiosis in such cases, which could be related to the early infection related mortality when we treat them with something like 7 and 3, which is very, very intensive. Across all the cancers, 7 and 3 is regarded as the most intense chemotherapy regimen. Now, the relapses are in excess of 50%. It means the way we are consolidating them, those patients who are surviving the first month, it is possibly not the right way. And we require better relapse preventing treatment. This had been an age-old treatment. I mean, since 1973, 7 and 3 had been the cornerstone of AML patients. I would say if 7 and 3 is one treatment to all these cases, the other treatment used to be best supportive care. It is either used to be all or none. But with time, we have understood this disease rightly, and in the last decade, this had been the era of massive genomic surveys. We understood this disease better. We understood that the number of mutations are pretty much there. The NPM1 and FLT3 are present in 1/3 of these patients. And this is the latest improvement. Now, in the ELN classification, the way we have started from FAB, now we are in a molecular era of AML classification. Now we understand this disease lot better than what we used to do a decade back. In the favorable types, now we have molecularly defined entities. Previously, it used to be NPM1 with or without FLT3 ITD or FLT3 ITD with a low allelic ratio. Now it is only NPM1. The SEPA mutation in the last decade, it had only been refined. Initially, we thought it is SEPA which is doing the favorable risk. Then we understood it is the biallelic or double mutated SEPA. Now we understood that the SEPA mutation had to be there in the B zip region to make this thing a favorable risk. Otherwise, all the rest of the SEPA mutations are bad. And the intermediate is mainly on the FLT3 ITD AML patients. With adverse risk, there are a lot of cytogenetic based adverse risk stratification. I want to get your attention to this one, that those patients who have got mutated ASXL1, BCOR, ASRIN2, RUNX1, SF3B1 and all these mutations, they are to be classified as adverse risk AMLs, even though their bone marrows by morphology are not showing a lot of dysplasia. So in both these ways, I mean, we have improved on 7 and 3s by increasing the intensity. This is mainly with perspective of waste, by increasing the intensity of donomycin by adding cladribine, by adding a FLT3 inhibitor in patients who are FLT3 mutated, by adding a monoclonal antibody like zamtuzumab ozogamicin, especially in the core binding factor AMLs, by giving 3 and 7 with lipids. I mean, CPX 351 is just very similar. We'll discuss about it. It's called as microtransplantation, which is practiced in many institutions across China. And there is also granulocyte transfusions or something called as myeloid progenitor cells, which has also been experienced to be nice options in these cases to prevent the infection. There is also improvement on the best supportive care. Now, from best supportive care, people have actually gone on to hypomethylating agent or usage of low dose RSCs. Now, after the advent of venetoclax, this part is blasted. Now, very few patients are actually getting best supportive care as an option. There is also some information about HR pathway inhibition and as well as IDH inhibition. So, I would draw your attention to this abstract, which was presented in ASH 22. You could see in the US, between 2013 to 2021, only 6% of these patients are not getting any treatment. And this number used to be a lot higher previously. It is just because of availability of low intense treatments like azacitidine, decitabine with or without venetoclax. So, how do we treat AML patients in India? Chemotherapy. Now, the intense chemotherapy candidates are those patients, because this is the first step, it should be for the patients who are curable without BMT, and now they are the favorable risk AMLs. The second is they should be extremely fit. They should have good general condition, zero infection status. Those who have got good support, be it financial as well as social, and good understanding of what is happening, what is going to happen in these cases. Now, these are the patients who could be cured without doing a BMT only by chemotherapy, according to ELN 2022. And these are the CBF AMLs, NPM1, only NPM1 mutated AMLs, and SEPA in the BZ region. Now, this is the biology to start with. Now, after starting these patients on treatment, we should be able to see what is happening to their MRD. If these patients are achieving a reasonable MRD either after 2 cycles or at the end of treatment, these patients have got a good prognosis. And if they are not getting these milestones at these requisite time points, they might not have a good favorable outcome as their defenders. Now, this is the data from 2 institutes. One is from MD Anderson Cancer Center, one is from Peking University from Beijing, China. And this is about the core binding factor AML patients. Now, as you could see, if you compare with US, the Chinese patients are at least a decade early. They are the 40s. The AML ETO percentage in the US is 48%, while in Beijing or China, it is close to 2/3. Now, this had been also the experience in India that within the CBF AML patients, we have more of this AML ETO or translocation 821s. When you look into the KIT mutations, the KIT mutation is supposed to be a bad risk mutation. It is present in close to 20% patients in MD Anderson Cancer Center, and it is in 1/3 of patients in China, and 50% of it are the worst KIT mutations, that is D816 or D820. In this study of MD Anderson Cancer Center, they don't do BMT, and in this analysis, they have conducted 40% BMT in the favorable risk patients. Now, when you look into the outcome, at a median follow-up for 8 years at MD Anderson Cancer Center, at a median age of 51 years, close to 60% of these patients are surviving, which is irrespective of whether there is a KIT mutation or not. Now, there is a split here because most of the patients at Beijing, they are treated with a 3 and 7 leg regimen. The 3-year overall outcome for patients who are KIT negative or those who are bad KIT negative, it is close to 66.7%. But when you look into the KIT mutated patients, that is the D816 or 820, it is only 6% of these patients. Now, I believe those patients who have CBF AML, they can be cured with chemoimmunotherapy. When we add zemtuzumab ozogamicin, as shown in this one, this is a study from MD Anderson Cancer Center. This is a retrospective study. FLAG-IDA had been the old approach. FLAG-O is the recent approach. As you could see, there are patients getting cured. And mind you, those patients who are less than 60 years, close to 80% of these patients are cured with only this approach. Those patients who are more than 60 years, close to 60% of these patients are getting cured with flago-based approaches. Flag-IDA, they are somewhat worse than flag-go. Now, this is about achieving a major molecular response with respect to AML-A2. Now, if there is a decline in AML-A2 for more than 3 log reduction, the outcome is supposed to be better, especially when it is happening in the mid consolidation. With respect to Zemtuzumab ozogamicin, when you see post-induction close to 70%, at the end of treatment, close to 100% of these patients, they are achieving a major molecular response. The same number for the Beijing data, it is close to 40%. That's why the Asian patients, they possibly, the CBF AML, they should not be only leveled as favorable risk. You need to risk stratify these patients. Now, this is a plot to differentiate between AML 821 and inversion 16. Now, you need not be a molecular biologist to understand what is happening here. As you could see, this cartoon is about 821 and this cartoon is about inversion 16, and they look completely different. The similarity is with the tyrosine kinase pathway mutations like c-KIT, FLIC3, maybe JAK2, maybe CVL mutations. But when you look into the dissimilarities, they're happening at the level of chromatin modifiers, at the level of DNA methylation, or having cohesin mutations. So in a way, these ETO positive patients who are CBF, they could be more complex than your inversion 16 rearrangements. And this is a nice analysis from them. Now, those patients who have got mutations in the chromatin modifier in addition to the tyrosine kinase mutation, let's say a patient who is AML-A2 who has got ASXL2 mutation, which is an epigenetic modifier, and a c-KIT mutation, these patients are going to do worse. And the chances of relapse in these cases can actually touch 60%. And this data is from pediatric AMLs. Similar data is not available for adult AMLs, where the incidence of relapse may actually go up. And this is one analysis from China, where they have randomized patients. They're not randomized, these are observational studies. They have treated patients according to their MMR. Those patients who have achieved MMR, they have not transplanted them. Those patients who have not achieved MMR, they have suggested a BMT in such cases. Now, in low risk patients, if you see, these patients can be cured with chemotherapy alone. If you perform a BMT, this patient might have a worse outcome because of the transplant related mortality. But when you look into the high risk patients, the incidence of relapse can actually touch to 80% of such cases, those who do not achieve an MMR at mid consolidation. And transplant can actually benefit in many of these cases, and the overall survival can actually reach towards 70%. With chemotherapy only, even if they are favorable risk, they can only touch close to 20%. So, to cure CBF AML, we need to understand it. At least we should have information about the c-KIT mutation, which can be there in 30 to 40% of the patients. These patients required to be treated with Zemtuzumab and chemotherapy. Again, the co-mutations that we have described, if they are happening both at epigenetic machinery as well as in the tyrosine kinase domain, these patients require more than chemotherapy. And in a way, all these patients who are CBF, they should receive Zemtuzumab ozogamicin based therapy, with which they can be cured. Now, countries where Zemtuzumab is available, it can take care of bad biology. Only 10% might require BMT. In countries like ours and many other countries where GO is not available or not affordable, close to 50% of these favorable risk patients might actually require BMT to cure the problem. Now, this is one of the cases that we happened to treat. He was a 15-year-old male. He was a case of normal karyotype, but ETO positive. NGS was not done at the baseline. He was treated with 3 and 7. He had a stormy course. He had a multi-drug resistant gram-negative bacteria and a chest infection. But nevertheless, after the first 3 and 7, he achieved a CR who was flow negative, and followed by 3 HIDA consultation. The molecular response was not checked. This patient had actually relapsed after 1 year. All this treatment had happened in a private hospital with government support, and because of the socio-economics, the patient referred to us. When we attended this patient had fever as well as chest infection. Even at a 15-year-old age, there were also fund issue. We have given him some abbreviated azacitidine and venetoclax. He had febrile neutropenia. He grew a gram-negative bacteria, but it was not the same bacteria that he grew in during the 3 and 7. We did his molecular. He had FLT3 and KIT negative. His NGS was suggestive of he was having A2 positive. He had an ASXL2 positive, and he also had IDS2 positive. This patient achieved a complete remission after cycle 2. During this whole treatment, he required admission of close to 2 weeks in the hospital. They had time to arrange for funds for the BMT that is required after achieving CR. Now he had completed 4 cycles and he had achieved a major molecular response with respect to the ETO. His donor is a haploidentical donor, his father, and he is now ready for BMT in a good general condition. So this case actually tells us about, how these patients can be salvaged with low intent treatment, especially when you are pushed to wall. Patient has lot of problems with respect to their general condition as well as funds. To some extent understanding, then Azaven could be a nice option. And because in tertiary care institutions, these patients they require to wait to get into the hospital to receive the intense treatment. Intense treatment is never started at an OPD basis. So this patient was curious with respect to how he responded to only a BCL2 inhibitor with azacitidine. Now, venetoclax is approved in both CLL as well as in AML. Now, CLL patients are very venetoclax sensitive, and that appears from its responses and the instances that it causes tumor lysis syndrome. We have never heard of tumor lysis syndrome in chronic malignancies, indolent malignancies, apart from this only issue that when CLL is treated with venetoclax. It is related to the apoptosis of such cases because the apoptosis of these CLL cells, they are mainly driven by BCL2 and not by something called as MCL1 or the other BCL members like BCLXL. So CLL patients are very venetoclax sensitive. Now in AML patients, we do not see any tumor lysis syndrome as it happens in CLL, and the responses as compared to CLL are not that great. They are sensitive, but not as sensitive as it is in CLL. In AML patient, what happens is AML is moved by both BCL2 as well as MCL1. There could be some other BCL analogs as well. Now the MCL1 inhibitor had to be given in such cases in AML. Now with respect to CLL, the MCL1 inhibitor is ibrutinib. When you combine venetoclax and ibrutinib, the responses are even better. For AML patients, the MCL1 inhibitor is either hydroxyurea. Hydroxyurea reduces the MCL1. It could be hypomethylating agent or it could be the intense chemotherapy, in that order. The maximum MCL1 inhibition could be achieved by doing chemotherapy in addition to venetoclax. Now, these are some preclinical studies which tell us that BCL2 inhibition could be there in only few AMLs which are, let's say, expressing RAD21, CATA2, SEPA, which are biallelic, NPM1 or IDH mutated, to name a few. Now, this is another case. He is a 39-year-old AML. He had normal karyotype, and this was his NGS. He had double SEPA. One SEPA is actually in the B zip region. Now, this patient, he came to us during 2019, and this was when there was a lot of COVID-19 restrictions. And during this, we hardly had any staff to take care of such cases. Everywhere we had to take care of COVID-19 patients. He was a young patient. We explained him everything. And this patient also had RAD21. So he was suggested Azaven because during that there was a lot of restrictions. And with Azaven, this patient had complete remission and MRD was flow negative. And This patient, during the first cycle of azavan, he never required an admission. There was minimal transfusion and antibiotics. So in a clearly selected patient population, azavan could be a useful way of treating such cases without causing a lot of toxicities. This is an interesting retrospective analysis of comparing azavan with 3 and 7. Here, when you look into this analysis, the 3 and 7 is actually doing a lot better than patients with azavan, which is marked with the red curve. But when you match patients according to their molecular cytogenetics and age and general condition status, azavan is not looking inferior than 3 and 7. Now, this is not a very good quality data, but nevertheless, it hints towards one thing, that azavan could be another option in clearly selected cases. And if it can be used well, these patients can be cured. Now, this is the analysis when venetoclax is used with intense chemotherapy. This comes from MD Anderson Cancer Center. Their intense chemotherapy is something like FLAG-IDA or CLIA. So they have added venetoclax to that. And across all this favorable, intermediate or adverse, it had produced more responses, which is statistically significant in patients who are intermediate or adverse risk. And this is a propensity cohort analysis between their intense chemotherapy versus their intense chemotherapy with ven. Now, as you could see here, this analysis includes patients who have undergone transplant as well. So patients who have received venetoclax in addition to intensive chemo, it appears that they are getting better cure. So it means venetoclax is also taking care of the leukemic stem cells. But the question remains, what should be, how much chemotherapy is required in addition to venetoclax? Because venetoclax is also myelosuppressive, it has got GI side effects. So these things are cumulative. And we are talking about centers like MD Anderson Cancer Center where the infectious mortality is less than 5%. And if we had to apply these things in our countries, the infectious mortality could actually increase if we use the same doses. Now, as you could see, this is a low intensity one, that is clad LDAC ven. And if you look at the median age, it is close to 70 years. And these patients are achieving equal amount of remissions as compared to other ven and intense chemos. So with venetoclax, you could actually go down on your intense chemotherapy schedules. And these patients can actually be MRD negative. So the duration and the dose of venetoclax in these patients were developed as per MTD. But how much venetoclax is actually required, it is not clearly known. It is given for a period of 2 to 3 weeks. With azoles, when they use a lower dose. With high CYP3A4 inhibition, they use 50. With moderate, they use 100 milligram. For say with posaconazole, they will be using 50 milligram veni and 100 milligram with something like voriconazole. The duration is unclear. Now, when you look into, this was an important abstract presented in March 22. They have shown that when they have given venetoclax, when venetoclax is continued till 28 days. Now, mind you, when you add venetoclax with azoles, their efficacy, their inhibition, it could not just stop at 7 days. It can go little further. At our country, we use venetoclax with azole for all the patients. So we need not give venetoclax for a period of 21 or 28 days. And if this data holds true in larger analysis, giving venetoclax 100 milligram with azole for 7 days should be enough in our cases. So this interested us, and now we have started a phase 1b2 study at our center where we are giving venetoclax of 100 milligram voriconazole for 7 days. And the chemotherapy, we need to identify that how much chemotherapy is given not to cause a lot of mortality. So we have reduced down, our level 1 dose is 2 plus 5. We have recruited 3 patients. It appears that even at 2 plus 5, the infectious morbidity could be high. So after we discuss it within our department and ethics, we might still go down on the dose of 215. Maybe the next level will be something around 45 and 100. That is a speculation. So the second thought is, who should not get intense chemotherapy? Now, intense chemotherapy, it entails 20 to 30% mortality in our hands. Now, those patients who clearly require BMTS consultation, that is the intermediate or poor risk, should we give intense chemo or should we give low intense chemo? It remains a thing for the future. I mean, this is a very important research question. In US, people are started doing an RCT. We have to wait for the final results. These patients have high probability of early mortality. Those patients who have got high probability of early mortality should not get intense chemotherapy. Those patients who have got poor support, be it financial and social, and poor understanding as well, they are not good candidates for intense chemotherapy, in my opinion. So who are the AML patients that require BMT? At least those patients who are poor risk to start with or intermediate risk, they are candidates for BMT. Now, just to refresh your thoughts, these are the intermediate. Intermediate mainly is about FLT3 and some 911, and adverse is mainly the NGS defined and some cytogenetic rearrangements like 6-9, 8-16, inversion 3. Now, this is an important information. In older AMLs, that is from 60 to 75 years, can we topple 3 and 7? This is CPX351. CPX351 is giving daunorubicin and RSC at a specific molar ratio in lipids, as shown in this picture. Now, this is a randomized study which randomized between CPX351 and 7 and 3. And they have found that the complete remission. Now, mind you, the dose of CPX, if you look at mathematically, it is only 45 and 100. And there are only 3 doses of CPX. And daunorubicin is 60 and 100 is RSC with 3 and 7 regimen. So even with the lower intense like CPX351, you could see the CRs are better. The induction mortality within 30 days and within 60 days are a lot better with CPX. And the overall survival as well, they are better. Now, the other interesting point is those patients who have undergone transplant after CPX of 7 and 3, it appears that those patients who have taken CPX in past, they have done better than those patients who have 7 and 3. So these chemotherapies, they don't stop at getting you into CR. They might have some non-elapsed mortality events which might be happening when you will be conducting BMTs in such cases. Now the question comes, in the poor risk subset of patients between CPX351 and Azaven, which one is better? This is a retrospective analysis from the health records. As you could see, the overall survival, it is not at all different between Azaven and CPX351. These patients are predominantly poor risk older. And this is the information. The top 2 curves are patients who have undergone transplant. If not similar, the Venaza, it might appear a little better. Those patients who have undergone BMT after Venaza, they might have a better outcome than patients who have undergone a BMT after CPX. It could just be due to the non-elapsed mortality thing. There is no science behind that. Now, this is another patient. We got a AML patient. She was only 19-year-old. She had menorrhagia, some high WBCs. Her cytogenetics was normal karyotype. Molecular pattern was all NPM FLT3 and all core binding factor were negative. Now, this patient had this NGS to start with. She had 2 NRAS mutations and 1 PIDM1 mutation. We are given a 7 and 3. It was complicated by febrile neutropenia. She had a disseminated cutaneous fungal infection, and the bone marrow at the end of 21 was started on Asaven. Now, these mutations are not very, we don't know how to classify these mutations. We also did a RNA sequencing in this case. At this point, it was found that this patient was having a DECNUP, a 6-9 rearrangement. Now, post Azaven, after the first cycle itself, this patient achieved a complete remission. Now this part is actually interesting. The patient's not achieving remission with 3 and 7, but achieving remission with azavan. So I would say patients who have AML with poor risk, we need to identify them well by doing an NGS. We should include both RNA as well as DNA sequencing. Assignment could be a paper based on our CTX and for that thing over 3 and 7 as well. Now people are adding CPX with because CPX is a good way of giving chemo. And additional medical now it is explored. It remains to be seen whether it is blocking as a way. These patients will require DMD information. I will discuss about TP53 AML, but TP53 mutation, chemotherapy as a is better. Between hypomethylating agent or additional venetoclax,
Ranjit,
there is no difference.
Ranjit, you put off your video, your audio now, the voice is getting. You put off your video. Put off your video, your audio. Now the voice is getting.
Okay.
Put off your video.
So is my voice clear now?
Much better.
Okay. Now let's come to the AML who are FLT3 mutated. This is the RATIFY study, and we know that adding a FLT3 inhibitor to a 3 and 7 backbone, it improves the overall survival. These patients, those who are transplant eligible, should get a transplant in CR1. As you could see in transplanted patient in CR1, they can achieve a CR. They can achieve a cure close to 80%. Now, this is another study which has used quizartinib. This is recently published in Lancet. This is only concentrating on FLT3 ITD mutation ratified both ITD as well as TKD. As you could see here, patients who receive quizartinib with 3 and 7, there is a better overall survival benefit. Now, what about treating FLT3 mutated patients with azavan? With patients who have FLT3 ITD, azavan doesn't do better than only aza, but in TKD it might have some responses. So what if we use both a FLT3 inhibitor as well as a BCL2 inhibitor? Now, as we are discussing, FLT3 mutated patients, they are driven by both MCL1 as well as BCL2. Now, when you are using FLT3 inhibitor, it is inhibiting the MCL1 part, and when you use venetoclax, it is inhibiting the BCL2 inhibitor. As seen in this study, which has incorporated mainly the relapsed refractory patients with only gilteritinib and venetoclax, they achieve a CR of close to 85%. Now, in both RATIFY study as well as the quantum study, the incidence of CR is not exceeding even 70%. And in relapsed refractory patient with both gilteritinib and venetoclax, the CR rates are crossing 80%. So we need to see, whether we should be more smart about it. Now, when you add all these three together, the low intense chemo, hypomethylating agent, and a FLT3 inhibitor and a venetoclax, the CR rates can actually go on to 90%, and close to 96% of these patients, they might have PCR negative toxicity. And if you do a particular flow cytometry, 80% are flow cytometry negative. Now, the triplet combinations in AML who are FLT3 could be more impressive and could be more protective than chemotherapy. But ideally, we should do a randomized study to see whether doing this low intense therapy, more targeted therapy, can produce better results than doing a chemotherapy plus FLT3 inhibition. This is a phase 1-2 study which included some 20 patients of newly diagnosed and 20 patients of relapsed and refractory. You could see this is at a short median follow-up, but what survival is close to 80%. This is very interesting. Now, this is one of our cases. To cut it short, he was a FLT3 mutated patient and we transplanted him in CR2 This patient had a haploidentity in the first 3 months, but at somewhere around 9 months, we could not give him a lot of FLT3 inhibitor post-transplant, because whenever we used to start him with FLT3 inhibitor, his GVSD used to get complicated. Post 9 months, WT1 as well as ERP. Now, whenever we say FLT3 with WT1, it means that it could be, and a rearrangement between NFP98 and NSG1. We did an RNA sequencing, which was found to be this NFP98 and NSG1 combination. This patient at relapse, because he had just an acute GVSD which was just controlled. He had lost some 20-30 kgs. Just gave him Azaven and Mido with donor leukocyte infections. He had complication with blinded leukemia and low respiratory tract infection. This patient had a CR and MRD. The timer which had declined initially during relapse returned to 200%, and there was no GVSD. So this patient had been continued on Azaven and DLI. I think at the last follow-up, this patient is continued to innovation, and we repeated RNA sequencing. Is RNA sequencing negative? So the BMT has again started working on it, and possibly this patient is cured, but we are not sure whether to stop all these things or not. We have stopped DLI, but we are continuing as of Mido, and we have increased the duration. So the question is how to take early mortality. We do not get crystal balls to look for it. This is a node study which had only looked into age and performance factors. So even if the patient is having less than 50 years, if his PS is poor, like 3 to 4, the patient mortality could be from MD Anderson Cancer Center, where they have taken these demographic variables like age and PS, presence of infection, especially pneumonia at diagnosis, having chromosomal abnormalities to take, whether they are favorable or intermediate or poor risk, and the lab data like total bilirubin, creatinine, and uric acid. And with this easy markers, they can actually predict the mortality. If the risk score is anything 4 or less, the induction mortality will be 10% or less. If it is crossing 5 or more, then the induction mortality is going to 20% or more. So it could be a useful analysis. Now, this is a work from Hematological Cancer Consortium led by Dr. Smita Kal from JIPMA. And she also looked into all these baseline variables. And she also predicted the mortality with this simple calculation. And the area under curve is close to 90%. So if we do all these things before taking these patients for high intense chemo, we could be able to predict that whether this patient is having early mortality or not. Now, this is one study where they have used peripheral blood stem cell transplantation. They call it as microtransplantation because AML patients, the 3 and 7 regimen is mainly myeloid suppressive. They are not lympho-suppressive. And when you give peripheral blood stem cells, let's say at day 9 or day 10, which is called as microtransplant, most of the stem cells, they are getting rejected. But what these peripheral blood stem cells can do is they can reduce the early infection related mortality. And because there is also the lymphoid progenitors are there in the peripheral blood stem cells, they can give some sort of anti-leukemic effect, just like DLIs. The interesting part is when these PBSCs are given, the recovery is faster in such cases by close to 5 days. And we know that in 3 and 7, having an early recovery by 4 to 5 days, these patients can actually be saved a lot better than when we don't do this microtransplantation. This is another thing, and this is coming from US. Now, from the stem cell product, they have removed the lymphoid progenitors, and they have also expanded these cells ex vivo. They call it as myeloid progenitors. Now, once these cells are infused, after say 4 or 5 days, they would be producing neutrophils. Now, this is the treatment schema. They just give it shortly after completion of 3 and 7 regimen. And if you look into the infection profile, those patients who have received this myeloid progenitor cells, they have lot lesser infection. They have less time in the hospital. So all this cellular therapy be it microtransplantation, be it myeloid progenitor cells, they could be useful. I have willfully not discussed granulocyte transfusions because there is no good quality data supporting the usage of granulocyte transfusions with respect to AML in some sort of a randomized comparison cohort. But having said that, in carefully selected patients who do not have a lot of chest infection, granulocyte transfusions could be useful in patients who have got multi-drug resistant gram-negative infections. Now let's come to this mortality calculator, which was done by Dr. Spitha. If you look into the variables that have given more importance, it is like creatinine, it is platelets, it is albumin, it's bilirubin, it is the symptom duration before the patient presents. Interestingly, infection at diagnosis, the age of the patient, or the performance status of the patient as it is found to be important in the MD Anderson Cancer Center cohort, they were given less importance in this calculator. Now, why is it so? So it definitely tells us that something is working beyond infection in our set of patients. Now, I will focus on this part in few slides. Now, there is something called as inflammation, which is sepsis, and there is something called as hyperinflammation, which is HLH. These two things cannot be differentiated, and in any clinical setting, it is very difficult to call a patient is having HLH and not severe sepsis, especially when he is growing a bacteria in the blood. Now, this is a group which has differentiated between sepsis and HLH by doing a flow cytometry, which is a very simple flow cytometry. If you look into the CD8 positive T cell phenotypes, in HLH, you will find that there is a high expression of both CD838 positive as well as HLA-DR positive CD8 phenotypes. You could actually differentiate between sepsis and HLH. Now, I will discuss two cases. One case is post-chemotherapy. He got an intense chemotherapy. He is a 40-year-old male and he had this sepsis. We did his flow cytometry. He had a very torrential course during the treatment. He's still like into his flow cytometry, we found the same thing. His CD38 positive and HLA-DR fraction of CD8 positive T cells, they are actually very more. And when you look into the CD5 loss, there is actually very few amount of CD8 positive T cells which are actually CD5 positive. We compared with another case who had HLH at the baseline, and as you could see, this patient was not treated and she actually got azacitidine and venetoclax because of her performance status. When you look into these two cases, the incidence, the first thing is you could identify HLH in patients by looking at their CD8 positive phenotypes, and you could look at the intensity. This patient had CD5 loss. There are some cells which are CD38 positive and CD5 negative. In these patients where the cytokine storm is very terrible, it is a very bad cytokine storm, there is no T cells which has CD38 positive and CD5 loss. Finally, differentiated these effector cells, you will find that a lot of patients have, lot of these cells are the effector memory in the in this patient who doesn't have a bad CRS, and in the patient who have a bad HLH, you could see most of the cells are the effector memory. So by doing the flow cytometry, you could get information which is beyond your blood cultures or beyond your other investigations, and it can actually suggest you that there could be something else happening beyond infection, which is HLH. Now, this study was recently published. This study didn't get a lot of attention. It was only published as a letter to editor in Hematologica. And they have treated patients who had HLH at the baseline with chemotherapy, which included antimetabolites like fludarabine, flag, or similar regimens. And in addition to it, they have also used dexamethasone, etoposide, and ruxolitinib. And they have found that The HLH markers with this regimen, which is called as red, they have actually declined. Won't go into detail, but patients who are having infection, they could be having infection as well as HLH, and careful immunomodulation in such cases can reduce the induction related mortality. In this letter, they have published 6 patients, out of which they have salvaged 5 patients with this approach. The other thing is gut dysbiosis. Most of these patients, they come to us with lot of antibiotic exposure, and when we do intense treatment in such cases, it only get worse, which is related to the induction mortality. So possibly patients who have gut dysbiosis in addition to AML should not get a lot of chemo. They should get low intense chemos. Now the second question is, after the initial 1 month, how do we maintain the remission? Now there is close to 50 or 55% of these patients are relapsing after attaining a remission. So how to do that? I will be very brief at this point. This patient should receive, I guess, CR1 BMTs. And this is an analysis from CMC Velo. They have compared their allogenic BMTs done at CR1, and they have compared these 2 regimens. Should we do myeloablative conditioning or should we do reduced intensity conditioning? As you could see, in their hands, their reduced intensity conditioning, those patients are living far better than patients who are getting intense conditioning. And this is one of the analysis. This was not a planned analysis, but this is how, if you conduct a BMT in CR1 in our cases, it could actually be cost effective and cost you less than doing all the induction and the consultations. So to conclude my talk, AML in young Indians remains a curable malignancy, but we should not do a lot of harm in cases who are not suitable enough to receive intensive induction. We should find ways to get the patient to a CR safely. Like this poor risk patient where azaven could be as good as a regimen with lot lesser toxicities. And maybe in FLT3 AMLs, my prediction is possibly in FLT3 AMLs, if we use this triplet of aza, ven and FLT3 inhibitor, we might get as good results as with chemotherapy. These patients will be more prepared for BMT because BMT had to be conducted in CR1. So these patients can better be resolved in a lot sweeter way than being intense. AML remains a costly disease. Now we need to be very innovative in such cases. You should use something like azacitidine and venetoclax in such cases. Don't exceed venetoclax beyond 7 days. And venetoclax at a low dose of 50 to 100 milligram with azole should be enough in such cases. Now, as I have shown you in 2 cases, the non-infectious issues could be as important as infection. So while we are treating patients with intense induction, or maybe in some patients with even less intense induction this happens, we should be watchful and should personalize treatment in such cases. Careful immunomodulation in such cases can bail these patients out. BMT is curative in such cases and it should not be delayed. But the thing is, we need to bring down the non-relapse mortality associated with BMT, the morbidity, as well as the cost. These patients, when we are implying to do a BMT in the first remission itself, they should have enough time to arrange funds to get the BMT done. Now that can only happen when these patients, they have a reasonable amount of time apart from the hospital, which can only be achieved with less intense treatments. And in the last ASH, there was a study been published, especially in relapsed and refractory patients of AML, that getting this patient into remission and doing a BMT doesn't do any good as compared to just palliating this patient and doing the BMT in the right time. I would say finally, these are difficult to treat patients and we should enjoy the challenge of taking care of such cases. That is my last word. And I should acknowledge my patients, my teachers, and my students who taught me a lot. And this is the right day to do this presentation. Today is Happy Mother's Day. And if I may say so, mothers are the best persons to take care of difficult to treat conditions like their children. So thank you very much for the kind listening. I'll be happy to answer a few questions if we have.
Thank you, Ranjit. Wonderful talk. Enjoyed listening to you again. Maybe now you can put on your video. Let's hope that we can hear you well.
Yes, sir.
Okay. So before I open it up to everybody, I have a couple of questions for you.
That's it.
The first is, how robust is the data to show that the treatment of HLH has been possible and it has made a difference in the outcome?
No, sir. Sir,
I think you'll have to put off your video.
when you look into the retrospective analysis,
Ranjit, you'll have to put off your video. Can't, voice is getting.
patients are actually been misclassified as having.
Voice is getting.
Right, sir. So, sir, this data is not robust, sir.
Okay.
But in our hands, in our experience, we feel the steroid response to only steroids is close to 50 to 60%, if my math is serving me well. But using etoposide could be useful in such cases because etoposide is known to control the cytotoxic T cell storms. And the main problem will happen when you do intense treatments. Let's say the patient has already received 3 and 7. Now he is having HLH. The counts are very low, and doing etoposide in such cases could be very, very tricky. So I would say steroids should be used carefully, and these regimens like this red regimen, which was suggested by in the previous article, they can be given a thought.
Thank you. My second question to you is, can one extrapolate the data that you mentioned in relapse setting doing transplant without any treatment to the first line?
So absolutely, I mean, because if it is happening in the worst of the scenarios, then it should be happening in the first line treatment. But we require good quality data, sir. So let's say we need to create the data. This patient should be palliated and should be given some disease controlling drugs initially, and then to be taken for BMT with whatever response we have.
Right. And my last question to you is, if there is a when ASA-induced remission versus 7+3 induced remission followed by transplant, are the long-term outcomes different?
Sir, I have not made a slide about that, sir. This has been published from MD Anderson Cancer Center because their median age is 60, and close to 50 to 60% of them, I mean, this is just recently published. They have analyzed those patients who have received azaven, they are living as good as those patients who have received intense chemotherapy. But there is a difference. There is a difference with respect to the non-relapse mortality. The non-relapse mortality in patients who have received prior chemo is a little higher and statistically significant than patients who have received azaven.
Thank you. So now come to our discussants, and I also request the audience to put your questions in the chat box. We start with Dr. Krishnan.
Hi, Ranjit, thank you for the wonderful talk. I have two questions. I mean, many doubts regarding this core binding factor leukemia 821 you have answered. Is there a difference between 821 and inversion 16 in terms of associated mutations? You know, if you have 821 c-KIT, you know, the prognosis is poor, then you may have to think about transplant in CR1. But is the same applicable to inversion 16, or the associated mutations do not carry much weight in inversion 16? That's my first question. I will ask the second question later.
Right, sir. I mean, between 821 and inversion 16, the other mutations which are doing a difference is the mutations which are in the epigenetic modifiers, chromatin modifiers, like ASXL1 and some cohesin mutations like SMEC and the other mutations of cohesin. So they are mainly in the 821. So whenever an epigenetic mutation happens and it is there, and there is another mutation is happening in the tyrosine kinase domain mutation, This epigenetic mutation is making this tyrosine kinase domain mutation worse. That's why the outcome of 821 is worse as compared to inversion 16, where the incidence of this chromatin modifiers are lot lesser. But if you look into the inversion 16, those who are having chromatin modifier mutations and TK mutations, they are doing as bad as 821. So it is the molecular architecture which should make a difference and not the exact type, whether it is AML2 or inversion 16.
Can I ask a second question?
Yes.
Okay, so the intermediate risk AML, CR1, we all transplant if there is a suitable fully matched donor. But the dilemma comes if there is no suitable, fully matched donor, should we take them for a haplo in an intermediate risk CR1? Sometimes we develop a cold feet. So what is your answer for an intermediate risk CR1, no fully matched family donor or a MUD? Can we take them for a CR1, sorry, haplo transplant?
So this is a very, very tricky question, sir, and we should be very much. This requires a lot of discussion between the patient and the physician. We should be very much forthcoming with the thought that we don't do that many haplos that had been done at somewhere like Beijing or maybe at US. So in centers or in countries where they are doing alternate donor transplant from a very long time, there the outcome is as good as doing a mass sibling donor transplants. But in our country, knowing our restrictions, doing an alternate donor transplants, they may have a higher non-elapsed mortality than doing just a mass sibling donor transplant. This part had to be very clear. And in such scenarios, these patients, should be offered this thing. If at all they are, how should I say, if they agree to take the risk, it is wise to do alternate donor transplants in such cases than to wait for these patients to relapse, because we had enough amount of data, and these patients are not salvageable at first relapse. Only 50 to 60% could be salvaged with chemo, and then the non-relapse mortality would accordingly increase, because we do not have a lot of good relapse regimens as of today.
Correct. Okay, thank you. I also thought the same thing. Thank you.
Thank you. We'll come to Dr. Ramesh, but I'll take one question from the audience, similar to you just mentioned. So what is your suggested regimen for reinducing those patients who are refractory to the 7+3?
So it will depend on the general condition of the patient. If the patient is okay, there is no infection, the amount of antibiotic exposure had not been logged, there had been no bacteremia in past, perfectly fit condition as it we are treating him for the first time, then it should be another 3 and 7. But having said that, I would be amazed to see why this patient has not responded to 3 and 7, because if a young patient is not responding, there had to be some reason. So you should have all the molecular data, be it RNA sequencing or DNA sequencing, and you should take the decision then and there. If it is a TP53, let's say, they have got very high failure rates, then there is no point of going on 3 and 7. If it is a non-TP53 and just NPM1 or maybe another CBF AML, where there is some response to 3 and 7, I will go ahead and do another 3 and 7 in such cases. But there is a question that why this patient has not gone into remission. That question has to be answered first. Then second will be, what is the fitness of the patient to undergo further therapy? Now it is not like 3 and 7 is not active, ASA1 will be active. ASA1 could work as well, but I would say if it is a curable malignancy, then 3 and 7 should probably be better.
Thank you. Ramesh, your question.
Good morning, sir. That was an excellent presentation. So ASA1 is a wonderful combination for achieving remission in many set of patients. So my question is like, if for a fit patient, any particular group of fit patients, like in terms of molecular genetics or cytogenetic mutations, you prefer an ASA1 over 7+3?
That is a very nice question. Now, Now, there is some data about it. The information I have showed in one slide, that was 3 plus N versus azaven. There was a nice information coming out of that 3 and 7 versus azaven thing, because the data is pretty huge. Those patients who have got RUNX1 mutation, they tend to do better with azaven as compared to 3 and 7. Okay, this is the data from that. Now, all the poor risk molecular mutations, apart from TP53, they might actually do better with azaven than with induction chemotherapy. And there are some patients like IDH mutated AMLs. If you look into the data about 3 and 7 and azaven, and they are the only difference being those who are intense ineligible, they are getting azaven, and those who are good fit patients are getting 3 and 7. And the CR rates or overall response rates, the MRD negativity, it appears to be as good as azaven and IDH inhibitor as compared to your 3 and 7. When you use all three together, it appears better than what is happening there. Even with only azaven comparison, when you look into the azaven versus aza placebo, the IDH mutated AMLs, they tend to do better than your 3 and 7. NPM1, there is some confusion because NPM1 is a waste basket, if you ask me. And there are clear NPM1s which could be more responsive to azavens than 3 and 7, I guess. But we need to define that subset, which NPM1 is going to do better with azaven and not with 3 and 7.
Okay, sir. My second question is like in our center, we recently started doing MRD molecular monitoring for 821 inversion 16 and NPM1. So with the limited data, what we observed is like with azaven, we are not able to achieve a 3-log reduction in many of the patients. Whereas like for the patients not achieving the 3-log reduction, we have given 7 plus 3 in 1 or 2, and we have achieved a 3-log reduction. So can we like any data on that, sir? Like 7 plus 3 is slightly superior over azaven in achieving an MRD, molecular MRD negativity in favorable risk patients.
So the patient that I have discussed who was CBFML and achieved a CR and a molecular response, that patient was having an IDH2 mutation apart from the E2 mutation. That would have made him sensitive to azaven. The decision to do azaven or 3 and 7 in CBFML, it is purely based on the fitness status of the patient and the co-mutations. Like patients who have got c-KIT mutation to start with, you do 3 and 7 or you do azaven, both are equally bad in my opinion. 3 and 7 can get you remissions, but that won't be lasting longer. So it remains to be seen. I mean, because there had been some c-KIT inhibitors I haven't discussed willfully in this presentation, like avapritinib, which is used in some other solid tumors like GIST. Avapritinib could be useful in such cases where there is CBF AML and you are using avapritinib with either chemotherapy or with azaven. There is some data which is creeping up, which remains to be discussed. But in CBF AML as well, you have to look what sort of mutations are happening. If it is a FLT3 ITD mutation, you're using azaven and adding a FLT3 inhibitor in a patient who are not eligible for intense chemo, it could be a useful option. But I agree with you that with azaven, the molecular clearance, especially of CBF AMLs, could be slower as compared to your chemotherapy.
Thank you, sir.
Thank you, Ramesh. So we will come to Dr. Saswata after one question from audience again. So you're an elderly, unfit person who has relapsed after azaven. What do you do with him?
Now, if he is elderly, you have to understand that these patients, they do not get to a good attempt at a second line treatment. Having said that, we have to understand why these patients relapse while on azaven. There are a lot of studies which are going on patients who are progressing while on azaven. Now, close to 5 to even 10 to 12% patients, they are developing a FLT3 ITD mutation in such cases. Now, if you are getting a FLT3 mutation and this patient is fit, don't stop azaven. do ASA1, add a FLT3 inhibitor. There is a 30-40% chance that this patient will go into remissions. There are also some studies from MD Anderson Cancer. They have shown that the BCR-ABL is also increasing post ASA1. I think there are only few cases. You should look into BCR-ABL as well. If it is increasing, add a BCR-ABL TK and see the response. The other drug which could be useful in such cases is anti-CD47. We await more data, and patients who are progressing while on ASA1, they might be salvaged with addition of anti-CD47 if you and the other regimen which can be used in ASA1, because most of the time what happens is your BCL2 inhibition is perfect. Your MCL1 inhibition by azacitidine is not very good. It is only weak. So from changing ASA1 to something like cladribine, low-dose RSC and venetoclax, because cladribine and LDAC, they are possibly far better MCL1 inhibitor over ASA1. So that is also a non-intense regimen, doesn't have a lot of toxicity, might require admission. But yes, that is another option which can be thought of.
Thank you, Ranjit. Excellent answer. Yes, Dr. Saswata, go ahead.
Thank you, sir, for the excellent presentation. I have two questions. First is, if we are using ASA1 in CBF AML, so if we see that after 1 or 2 cycles of ASA1, we do not attain a flow MRD negativity, what should be our strategy and how long should we wait on ASA1 for MRD negativity? And my second question would be that if we attain MRD negativity.
Take your second question after he answers the first one.
Okay.
So let me be very technical at this time point. In the ASA1 studies, if you look into the ASA1 versus ASA placebo studies, in these patients, the good risk patients were actually excluded from the inclusion of clinical trial. So in CBF AMLs, ASA1 is an off-label combination. But yes, those patients who are ineligible for intense chemotherapy, ASA1 remains an option.
So his question was, how many cycles would you continue when you say that there is no response from the angle of MRD?
2 cycles, sir.
2 cycles.
It will be 2 cycles.
Your second question, sir, Saswata.
Yes, sir. So if we attain a flow MRD negativity after 1 or 2 cycles, then we consolidate with like HIDAC kind of therapy. So at the end of 3 cycles, if we see that there is no molecular, we do not attain a MMR, so do we consider for any maintenance azacitidine kind of those tests?
So, this is an interesting question. So this patient, it appears he is not transplant eligible. So if it is a transplant ineligible patient, by giving interferon in such cases, or by giving azacitidine or decitabine in such cases, might actually help in achieving the molecular responses. Now there are some reports. Even after BMT, if these patients are not achieving MMR, then they can be given interferons, alpha 2A or alpha 2B, or decitabine, to clear the E2 mutations. Now the thing is, the E2 mutation you should not achieve, you should not look for 0, because these mutations acquired very long back. So you should at least achieve 3 log reduction. That should be ideal. You need not attain 0. 0 is very, very less.
Thank you, sir.
Thank you, Dr. Sir. We'll go to Dr. Mukul after one question from the audience. In a KIT exon 8 positive pediatric AML, what is the response to intense chemotherapy?
So the KIT exon 8 mutations are relatively okay mutations. With respect to the pediatric AMLs, the impact of KIT mutations had not been very high. So KIT exon 8 mutations could still be salvaged with chemotherapy. If you ask me, I would add zemtuzumab ozoamycin given a chance, along with 3 and 7. Because in our experience with whatever data we have seen, the KIT mutations, they are not doing great. And you have to also look into the VAF. If it is anything which is beyond 20%, then these patients might not do as well.
Thank you. Dr. Mukul?
So, interesting talks, really. So, my question is one with respect to Azaven. What is your antifungal agent of choice when you are giving Azaven as an elective therapy? You go for posaconazole or you go for echinocandin or amphotericin to decide on the dose. And secondly, I'll ask the second question after that. Yeah.
So my go-to had been itraconazole, because itraconazole is available free of cost at our hospital in the generic pharmacy. So my go-to is itraconazole 100 milligram twice a day with venetoclax 100 milligram. Now recently we had some near expiry samples of posaconazole in last 3-4 months. It was given on compassionate basis by some drug companies. So we used posaconazole 5 ml 3 times, and we use venetoclax at a 50 milligram dose. So my go-to is itraconazole, but after using posaconazole in 10-15 patient, I feel posaconazole is as good a regimen.
And secondly, that data with with venetoclax for 7 days, it appears to be slightly, just an abstract and kind of premature to say or suggest such a regime as of now.
Yeah, you can actually look at it from two angles. Now there is data available with venetoclax, and they were compared with venetoclax with reduced dose venetoclax when they were given with azoles. Now when you look into the pharmacokinetic data, the 400 milligram venetoclax or 100 milligram with azole venetoclax, they look just the same. But when you look at the clinical outcome, those patients who have received venetoclax with azole, they have far more myelosuppression as neutropenia or thrombocytopenia. In different studies, they have reported that it is pretty longer as compared to when venetoclax was given as only 400 milligram and no azole was used. So it tells you two things. So with azole, we are getting the PK level as good as venetoclax 400. But I would say when we are giving azole, the intensity of BCL2 inhibition, it is more prolonged than when it is given without azole at full dose. So when we are giving 7 days of venetoclax with azole, that it is only a gut feeling that when we are giving only 7 days of venetoclax with azole, that could something like 10-12 days of venetoclax. So in our clinical experience as well, we need to stop it after some time, because the counts they drop quite a bit in such cases, and we have not found any differences, because post that study, those patients where the economics are low and the support is less, they only get that many days of venetoclax as a cited in 7 or 8 days maximum. We need to look into the data, but it doesn't look very bad than what it was prior. So I feel that is a reasonable approach, especially when cost is a constraint.
Sure, sir. And third, your go-to regime in relapsed AML.
In relapsed AMLs, those who are fit, we go for venetoclax based combination like flagedapen or maybe 3 and 7 ven. And now because we have started a study, those who are late relapses, we are uh, recruiting them to the clinical trial of venetoclax 7 days with 215. And those patients who are not fit, we give asaven.
Thank you. Thank you.
Thank you, Mukul. Before Dr. Akanksha, one more question from the audience. You mentioned about this flow cytometric differentiation of sepsis from HLH. So do you repeat the flow again?
No. This is what we have done in the last 1 month, and this data is only of 2 patient old. So actually, I have not repeated, but I'm planning to do so. What is happening with treatment, that I am planning to do so.
Fair enough. Dr. Akanksha, your question.
Good morning, sir. Thank you so much for that excellent presentation. It was good to know we also have a lot of Indian data coming up in this regard. You mentioned something about gut dysbiosis. So how to suspect and manage that, sir?
That was actually a general term. We have looked into it basically. We have looked into it prospectively. That in a prospective analysis, we used to do the stool culture for the commensals. Those patients who have received antibiotics, their stool culture is almost negative. And these patients were at higher chance of having induction mortality. We have also looked into some microbiome data about these patients. Their diversity, as compared to their baseline, they are decreasing. So gut dysbiosis, as of today, it is a general term. It had to be defined properly. Now, when the diversity is not more, it is less, this could be gut dysbiosis. In a clinical sense, those patients who have received antibiotics for more than 5 or 6 days, they are without a good food, because most of the patients, they are coming from far off, not taking proper foods, then possibly they are having gut dysbiosis. And the worst part is those patients who are actually having diarrheas after the antibiotics, they possibly will be having gut dysbiosis. These are clinical.
Thank you, sir. Now, one question. Any data for using azacitidine in fit kind of patients who are not so bad? Because our institute, I'm from Kidwai Memorial Institute of Oncology, Bangalore. We are using a lot of azacitidine. So, because we had a higher induction mortality, so we are trying to do this. Any suggestions or any ideas on this, sir?
So the only thing is, whatever we are doing, we record it properly and we look at it in our hands, and whatever as when we have done, because during this COVID as well, we had to do a lot of azacitidine and venetoclax in our patients. Now there are patients who will clearly benefit from 3 and 7, and there are patients who are clearly benefit from azacitidine and venetoclax. These biological subtypes are yet to be defined. Now, with the advent of venetoclax with almost everything, venetoclax with azacitidine or venetoclax with chemotherapy, all these things are actually narrowing it down. So our approach should be, venetoclax should be the bare minimum. Whether to use azacitidine or reduce intense chemo with venetoclax, it remains to be seen. Which one is better way to go forward? Those patients who are sick, they would be given only azacitidine in such cases, azacitidine with venetoclax. Those who are fit, they will receive venetoclax in addition to chemotherapy, which remains to be defined. Now, Chinese, they have published their data of using venetoclax of 14 days with 3 and 7. We need to find out because their induction mortality is not very high. It is within 10%, just like US. In India, with the induction mortality is going up beyond 20%, we need to figure out with venetoclax how much chemo we intend to give. That we need to decide. But anything which is closer to 215, which was seen in a previous study, it looks that with venetoclax 215 is almost sufficient.
Thank you, Dr. Akanksha. We'll be going to Dr. Amrita, and once again, we take a question from the audience. This is regarding high dose RRC versus intermediate dose, 3 versus 1.5 in a person who is not MRD negative after the induction. Your comments.
So the quality of data is lacking here. But looking at the way the RSC acts, an 18 gram per meter square or a 12 gram per meter square, it doesn't do any difference to the leukemia control. So those patients who are MIT positive after 1, 3 and 7, we are intending to give high dose RSC as a consolidation. 12 gram per meter square should be as good as 18 gram per meter square, if I believe so.
Thank you. Dr. Amrita, your question.
Thank you, sir, and thank you for an interesting talk. Now, my first question was, in terms of chemotherapy-related AML or MDS-related AML, what I believe is the MRC AML 19 trial showed that CPX 351, that's what they are recommending, but we have mostly data from the West. So what is your preferred treatment regimen for a chemotherapy-related or MDS-related AML in the Indian population?
It is associated in venetoclax. It is mostly
Okay, is that it?
it is
Do
TP50.
you generally use CPX 351? I'm sorry. Yeah, go ahead.
If it is TP53 mutated, then additional benefit of venetoclax is doubtful, because if the patient is old, you need not do venetoclax in such cases because it causes a lot of infection. So only azacitidine if it is TP53 and non-eligible for BMP. If he is eligible for BMT, I might consider adding venetoclax to get the patient into some sort of a complete remission and then take them for BMT.
Okay, thank you. The other one was in FLT3 positive patients who relapse and in whom you've previously used midostatin. So, in relapsed patients, would you give a retrial of midostatin, or would you give another FLT3 inhibitor generally, like a gilteritinib or?
Gilteritinib is not available as yet, but gilteritinib is definitely preferable. Now, those patients who are progressing while on a FLT3 ITD, we need to understand why they have progressed. If it is related to a FLT3 mutation, like acquiring another FLT3 TKD mutation or some other domain mutations, then midostaurin may not be active. If the patient is not having such mutation, just like imatinib or nilotinib, if it is not having that mutation, you could use the same drug, add venetoclax, and same chemo or low intensity therapy. That should be okay.
Okay, thank you.
Thank you, Dr. Amrita. One more question from the audience. If you have a FLT3 positive, elderly, ineligible for intensive treatment, on azavan and midostaurin, has achieved complete molecular response, how many months will you continue this treatment? How many cycles?
That is an interesting question. I mean, this treatment has to be continued till progression. That is ideal. But if I am sure that the molecular responses are great, then you could actually, after 1 year or maybe 2 years, you could increase the duration of cycles that you could do.
Dr. Krishna, your question.
See, one practical question. Nowadays NGS is available by many commercial labs and we use it often. So you think if a patient comes, we should wait for all the results and then take a personalized decision to initiate the treatment. Some with, I know, especially if they have got a poor risk, profile, they may not do well with chemotherapy. We can ignore chemotherapy and just give them azavan. So instead of rushing with 3+7, can we just wait for all the results to come for patients who are affordable to do all these molecular tests and then take a personalized decision about what to give?
So that is a great question. Now there is data supporting this thought. This data comes from the US, mainly from the MD Anderson Cancer Center. In AML patients, they have excluded patients who are having hyperleuc. Now, patients who are non-hyperleuc in a good general condition, they have seen that you can wait for a period of 5 days. They've analyzed that when you are waiting, for this much period to take a decision, it is actually not making the prognosis worse. So you could actually wait in such cases. Now, the Indian context could be a little different. If the patient catches some infection or the patient is prone to get such infections while waiting for such results, it could be counterproductive. This could only be tried for patients who live close by, within the same state, very close to hospital, in an excellent general condition. The CBCs are well preserved, and the ferritin and other things are pretty okay. Then that could be a possibility. But there is no good quality data. But yes, there is some suggestion that we can wait for the NGS thing to happen. And now, because many of these labs they are doing NGS at a shorter time, they can get it within 7 to 10 days. It could be a useful strategy in few patients.
Okay, thank you. Just one more question. You are doing a trial with venetoclax. But how do you manage the funds for venetoclax? I mean, it's not officially available, and
No, it is actually, these are, I mean, what do we call it? These are not company sponsored. We actually wrote to AbbVie about it. It has been 2 months since, and they have actually not responded. So it is out of our own pocket.
oh, okay. Okay, thank you.
Thank you, Krishna. Once again, a question from the audience. 85-year-old AML, normal cytogenetics, good performance status. AZA plus decitabine versus just a single drug.
As a so
Venetoclax is essential, or you can just give HMA.
no, but I mean, if the patient is in a genuine general condition, then it should be azacitidine and venetoclax, because it controls the transfusion need and everything pretty fast. So it is not very toxic, so it is with venetoclax.
Absolutely. Dr. Jaswantini, your question.
Good morning, sir. Well, I would like to thank you for such wonderful talk. And I have two questions. One is between AZA and decitabine. Can we prefer decitabine over AZA? Because in our institute, people have less talks, like less immunosuppression with decitabine than with AZA. So, what is your suggestion regarding starting decitabine over AZA, sir, along with venetoclax?
That is an interesting observation. I mean, between azacitidine and decitabine, there had not been any efficacy issues, even when they were used for stimulation. The difference with azacitidine and decitabine could be through the route of administration, because azacitidine is given subcutaneous. It doesn't require. I mean, the patient can take it at a local place as a subcutaneous injection. We do not exceed 100 milligram in a day, and it had to be given at 2 sites. And decitabine, even though the subcutaneous information is not great, it can be given as preferred is 30 milligram, 20 milligram per meter square, 30 milligram for 5 days. The patient has to come to hospital for 5 days. And if you look into the side effect profile, decitabine might be a little more emetogenic than azacitidine. But apart from that, possibly a little more myelosuppressive, as you could see in some previous data. But it is interesting that, I mean, if you are okay with that, then it is decitabine and venetoclax.
Yeah, sir. Actually, for our cases, like more than AZA, like decitabine has caused less febrile neutropenia compared to like AZA. So we routinely give decitabine over AZA. So I just wanted your confirmation. And my second question is AML with NRAS mutation, sir. What is your call for BMT, sir? Whether can we proceed for bone marrow transplant or will wait?
Actually, a little difficult to answer. I mean, because NRAS, as I have shown in that patient, she had NRAS and another peculiar PRDM1 mutation. Now, she was not falling into any bad categories. So, these patients will fall into the intermediate risk category. Now, NRAS just means that this patient could be more responsive to RSC, and they should get, I mean, treatment just like an intermediate risk AML.
Okay, sir. Thank you so much.
Thank you. One more observation from the chat box. Dr. Hita has mentioned that have you observed patients who developed GI mucositis after 7+3 have a higher mortality?
Yes. I mean, those patients who have, especially this neutropenic enterocolitis thing, they could become very, very sick. So those who have a lot of diarrhea during 3 and 7, they get sick. I mean, having this gut-related complications, be it during BMT, be it during your intense chemotherapies, it means bad.
Right. Last question, we have Dr. Baveja.
So for such an session. So in Indian scenario, what should be the dosing sequence of AZA, ven, and midostaurin? Because the toxicity of all these, the GI toxicity is always bothering for the patient.
That is an interesting question, because most of these drugs are actually developed on the MTD. So if you look into gilteritinib and venetoclax, they are given for a very longer duration. Now in our hands, what we believe is azacitidine, venetoclax, and midostaurin, if all the three are combined properly with azoles, we should not go beyond 7 days.
Sir, and
Very myelosuppressive.
sir, and secondly, sir, have you experienced the side effects related to cardiac side effects related to azacitidine and midostaurin combination?
Azamido, I have not seen. I have seen patients who were on azacitidine developing atrial fibrillation. I have seen that. And with venetoclax as well, we have seen a patient who was on azacitidine and venetoclax. They have developed some cardiac side effect. If you look into the azacitidine, venetoclax, and azacitidine placebo study, the incidence of cardiotoxicity is higher when you add venetoclax. The same thing happens when you add venetoclax with ibrutinib as well. The incidence of atrial fibrillation when you add venetoclax, it increases.
One more question is, sir, what is your experience with oral azacitidine and venetoclax combination?
The oral azacitidine, we actually,
So it's not a recommendation, but still.
oral azacitidine we actually used during this COVID-19 breakup in few patients. The problem with oral azacitidine is its bioavailability and its GI side effects. It can cause a lot of vomiting as well as diarrhea and constipation. And it is given as a 14 days on and 14 days off schedule. The patient had to take ondansetron for 14 days period, which is also very difficult for some patients to. A few of my patients, they have actually gone from oral azacitidine to subcutaneous azacitidine. They didn't like, oral azacitidine that much. And there is often there is one case who was on subcutaneous, had a lot of cutaneous reaction. She wanted the oral preparation. They can be used interchangeably, I guess. They are similar drugs, and the pattern is giving lower doses over a longer period, so it fits well. But oral azacitidine, I feel the GI toxicity is considerable, and the duration of antiemetics which is required to be given is 2 weeks. So not a very preferable one in our hands.
Thank you very much, sir.
Thank you. So I don't see any other raise hand sign and no questions in the chat box. So we come to an end of this wonderful session with Dr. Ranjit. Dr. Ranjit, I just close this by saying that one can prepare the lecture and deliver it beautifully, but your real knowledge, experience is tested when the experts sitting around are asking you questions. And the way you have handled all the questions from so many experts present over here and from the chat box was wonderful. It speaks volumes about your depth of knowledge and confidence. So thank you so much once again for sparing the Sunday afternoon and the whole background work that you've done to prepare this talk. We are grateful to you. Bye-bye.
Thank you, sir. Thank you very much. It's a
Bye.
pleasure.